Good evening. My name is Yoon Soo HAH from Daegu Catholic University Medical Center. I'm really sorry that I couldn't attend according to COVID guideline of our institution. Today, I will introduce a comparison of partial nephrectomy versus ablation therapy for small renal masses. Although radical nephrectomy is the most basic treatment for all renal tumors, nephron-sparing treatment, if possible, is a more reasonable option for preservation of renal function. These days, urologists contemplate whether to do partial resection or ablation rather than radical nephrectomy. Partial nephrectomy and ablation have been studied for a long time. There is a meta-analysis study in 2008 that analyzed 99 papers compared to nephron-sparing surgery. Significantly increased local progression rates were calculated cryoablation and radiofrequency ablation. However, no statistical differences were detected in the instance of metastatic progression. Because of the heterogeneity of data, there was a significant selection bias with respect to patients' age, tumor size, and length of follow-up. In 2015, a study of 1,800 T1 renal masses, local recurrence-free survival was similar among the three treatments in patients with T1A, whereas metastatic-free survival was significantly better after partial nephrectomy and cryoablation. Overall survival was superior in partial nephrectomy group. However, there was also significantly younger with lower comorbidity. A long-term data study from the same institution published in 2019, there was no statistically significant difference in 5-year local recurrence-free survival, metastatic-free survival, and cancer-specific survival. The authors conclude that percutaneous ablation showed acceptable results for T1 renal tumors and emphasized that it is useful in the treatment of patients who are contraindicated in surgical treatment. There was a larger volume paper in 2020, a study that retrospectively analyzed 38,000 T1 patients using sheer data. Partial nephrectomy showed a better adjusted overall survival and cancer-specific survival than ablation. However, they showed comparable overall survival in patients aged over 85, smaller mass under 2 centimeters, and chromophobe RCC. There have been several other studies, but it is still controversial which treatment is better. Therefore, a well-designed prospective study is needed, and appropriate application according to the situation is more important. These are the characteristics of both treatments. There is no doubt that a partial nephrectomy is not inferior in oncological outcomes. On the other hand, ablation has advantages in all other ways: less pain, less complications, and shorter hospital stays are helpful for patients for whom surgical treatment is contraindicated. Some complications of ablation therapy were reported, such as infection or hemorrhage. However, most are mild and much less than surgical treatment. From now on, let's look into the issues below. The first one is indication. The indications suggested by each association are still different and are usually not clear. EAU and AUA provided relatively detailed criteria. EAU suggested ablation therapy for old patients with poor condition, patients with genetic components, and solitary kidney or poor renal function. AUA proposed a cutoff value for tumor size. We often encounter some inoperable patients with small renal masses but larger than the indications. Ablation therapy for T1B renal masses has been studied in retrospectively analyzed of a total of 56 patients. 5-year overall survival, cancer-specific survival, and disease-free survival were all inferior compared to partial nephrectomy, but showed no significant differences. This means that tumor over 4 centimeters is not an absolute contraindication to ablation. With appropriate patient selection with such as age or tumor size, RFA can be an effective treatment option for T1B patients and has also shown better preservation of renal function. What we have to do about cancer that persists or recurs after ablation? The answer remains controversial. The first choice is an active surveillance. Pseudo enhancement may appear up to 1 year on follow-up CT. Another option is reablation, which is the most common choice for recurrent cancer after ablation and also showed favorable outcomes. The other is nephrectomy. Of course, partial nephrectomy could be advisable, but there could be complications because of the scars or fibrosis after ablation. There is a paper sharing the experience of ablation recurrences. They applied several treatments to relapsed patients, and some patients progressed to the tertiary ablation. Although this study did not provide clear guidelines for recurrent cancer, reablation was also seen as an effective treatment depending on the patient's condition. So we could not conclude that one is superior to the other. It is important to understand that characteristics of the two methods and determine which treatment is appropriate for each patient. Thank you for listening.